2 hours ago, the Federal Aviation Administration issued emergency directive prohibiting Canadian-registered medical aircraft from operating in United States airspace, citing concerns about foreign aircraft conducting emergency operations over American territory. The ban applies immediately to air ambulances, Medevac helicopters, and organ transport aircraft registered in Canada, preventing them from crossing into American airspace for medical missions regardless of urgency or patient condition. The directive was presented as necessary protection of airspace sovereignty and stated that American medical aviation resources are adequate to handle domestic emergency medical transport needs. The White House emphasized that foreign aircraft operating emergency medical missions raise coordination and liability concerns that justify the restriction. What the administration failed to understand is that rural American healthcare depends critically on Canadian air ambulance services because American medical aviation companies never built sufficient fleets to serve remote areas where patient volumes cannot support profitable operations. Canadian air ambulance operators filled this gap by deploying aircraft and crews to serve rural communities across the northern United States where every minute of transport time determines survival for heart attack victims, stroke patients, trauma cases, and high-risk pregnancies. Mark Carney responded from the headquarters of a Canadian air ambulance company in Winnipeg where dozens of helicopters and fixed-wing aircraft normally deploy across the border to serve American communities. Behind him, mechanics were preparing aircraft for missions, flight nurses were checking medical equipment, and pilots were reviewing flight plans. All those missions were about to stop. But before we break down how banning Canadian air ambulances just sentenced rural Americans to death because the nearest American trauma center is now unreachable for heart attack and stroke patients who have exactly 60 minutes to receive treatment before permanent damage or death occurs, hit that subscribe button and like this video. Carney began by explaining how medical aviation works in rural areas. Time is the critical factor in medical emergencies. Heart attack patients need cardiac catheterization within 60 minutes of symptom onset to prevent heart muscle death. Stroke patients require specialized treatment within the same window to prevent permanent brain damage. Trauma victims need surgical intervention within the golden hour. High-risk obstetric emergencies demand immediate access to facilities equipped for emergency deliveries and neonatal intensive care. Rural communities often sit 200 miles or more from hospitals with the specialists and equipment needed to treat these conditions. Ground ambulances traveling rural roads at 60 miles per hour need over 3 hours to reach distant trauma centers. By the time the ambulance arrives, the patient is past the survival window. Air ambulances flying at 150 miles per hour can complete the same journey in 80 minutes, delivering patients within the critical treatment window. Canadian air ambulance companies operate approximately 340 medical aircraft serving American communities, 180 helicopters for emergency transport, 120 fixed-wing aircraft for patient transfers, and 40 specialized aircraft for organ transport and neonatal care. These aircraft deploy to American rural areas because economics makes serving these regions impossible for American companies focused on profitable markets. A medical helicopter costs $5 million to purchase and $2 million annually to operate, including crew salaries, maintenance, insurance, and facility costs. The aircraft must fly enough missions generating sufficient revenue to cover these costs. Urban areas with high patient volumes support profitable operations. Rural areas with dispersed populations generate insufficient mission volume for profitability. Canadian air ambulance operators built business models that serve both profitable urban markets and unprofitable rural areas by cross-subsidizing operations. Revenue from high-volume urban missions funds aircraft deployment to rural regions where mission frequency cannot support dedicated aircraft. This model works because Canadian companies operate across the entire northern tier of North America, balancing high-volume and low-volume service areas. When Trump banned Canadian medical aircraft from American airspace, 340 aircraft serving rural American communities received immediate grounding orders. The aircraft could not legally cross into United States airspace to respond to medical emergencies. Canadian crews sitting ready to launch for missions received notifications that American airspace is closed to their aircraft regardless of patient condition or urgency. Carney announced that Canada will comply with American airspace restrictions by recalling all Canadian air ambulance aircraft currently positioned at American bases and cancelling all contracts for medical aviation services in the United States. He noted that if American policy characterizes Canadian medical aircraft as threats to airspace sovereignty, Canadian resources will redeploy to serve Canadian communities and international markets where emergency medical aviation is valued rather than treated as security concern. The recall was immediate and comprehensive. Within 24 hours, 340 Canadian medical aircraft departed American bases and returned to Canadian facilities. The exodus left massive gaps in medical aviation coverage across rural America, particularly in Montana, North Dakota, Minnesota, northern Wisconsin, Michigan's Upper Peninsula, rural Maine, and northern New York, where Canadian aircraft provided the only practical access to advanced medical care. The consequences became apparent within hours. A farmer in rural Montana suffered a massive heart attack while working his fields. His wife called 911 and requested air ambulance transport to the cardiac catheterization facility in Billings, 240 miles away. The dispatcher explained that the Canadian helicopter that normally serves the area has been grounded and recalled to Canada. The nearest American air ambulance is 400 miles away and currently on another mission. Ground ambulance transport would take over 5 hours. The man died before the ambulance reached the hospital. In North Dakota, a pregnant woman experiencing severe complications needed immediate transport to the neonatal intensive care unit in Grand Forks. The Canadian fixed-wing aircraft equipped for high-risk obstetric transport had been grounded. No American alternative existed in the region. Ground transport over winter roads would take 3 hours. The woman delivered in the ambulance 40 miles from the hospital. The premature infant died within minutes because the ground ambulance lacked the specialized neonatal equipment that would have been available on the Canadian aircraft. A logging accident in northern Maine left a worker with severe trauma requiring immediate surgical intervention. The Canadian helicopter that serves the region could have delivered him to the trauma center in Portland in 70 minutes, well within the golden hour. With the Canadian aircraft grounded, ground transport required 4 hours over rural roads. The patient bled to death en route because the ground ambulance lacked the surgical capabilities and blood products available on the air ambulance. Within the first week after the ban took effect, 47 Americans died from medical emergencies where Canadian air ambulances would have provided transport within the critical treatment window. The deaths included 23 heart attack victims who could not reach cardiac catheterization in time. These patients experienced chest pain in remote locations, called for help, and were told that air transport was unavailable. Ground ambulances arrived too late. By the time they reached hospitals, the heart muscle had died from prolonged oxygen deprivation. 12 stroke patients progressed to permanent disability or death during prolonged ground transport. Stroke treatment requires administration of clot-busting drugs or mechanical clot removal within the narrow time window. Patients trapped in ground ambulances for 3 to 4 hours exceeded this window. They arrived at hospitals where doctors could only watch the brain damage progress, knowing that air ambulance transport would have delivered the patients in time for life-saving treatment. 8 trauma victims bled to death before reaching surgical facilities. These were logging accidents, farm equipment injuries, and vehicle crashes in remote areas. The patients needed immediate surgical intervention to stop internal bleeding. Canadian helicopters equipped with surgical capabilities and blood products could have stabilized them during rapid transport. Ground ambulances lacked these capabilities. The patients died in the ambulances or shortly after arrival at hospitals. 4 obstetric emergencies resulted in maternal or infant deaths during transport. High-risk pregnancies experiencing complications need immediate access to facilities with neonatal intensive care. Canadian aircraft equipped for obstetric emergencies could provide this transport safely. Without air ambulance access, women delivered in ground ambulances without adequate equipment or specialist personnel. The outcomes were preventable tragedies. Rural hospitals reported desperate situations. Emergency departments that normally stabilize patients and call for air ambulance transport to tertiary facilities now faced patients they could not adequately treat with no practical way to transfer them to appropriate care. Doctors watched patients deteriorate knowing that the aircraft that could save them were grounded in Canada, banned from American airspace. American air ambulance companies responded that they cannot quickly expand to serve rural areas. Building capacity requires purchasing aircraft, hiring crews, establishing bases, obtaining certifications. The process takes years and requires investment that cannot be recouped in low-volume rural markets. Several American medical aviation companies stated explicitly that they have no plans to expand into the rural markets abandoned by Canadian operators because the economics do not support profitable operations. Without cross-subsidization models that Canadian companies use, American operators cannot sustain rural service. The result is permanent loss of air ambulance coverage in regions where ground transport times exceed survival windows for time-critical medical emergencies. Rural community leaders responded with fury. County commissioners in Montana passed resolutions demanding federal reversal of the aircraft ban and noting that the policy amounts to death sentence for rural residents who suffer medical emergencies. Hospital administrators in North Dakota held press conference standing beside empty helipads where Canadian aircraft once waited on standby, stating that federal policy has made advanced medical care inaccessible to their communities. The American College of Emergency Physicians issued statement condemning the ban on Canadian medical aircraft and warning that rural Americans now face third-world levels of emergency medical access. The organization noted that minutes matter in cardiac, stroke, and trauma cases, and that policies creating hours of additional transport time guarantee preventable deaths. Medical ethicists raised concerns about creating different standards of medical access based on geography. Urban Americans suffering heart attacks receive rapid transport to cardiac facilities. Rural Americans suffering identical emergencies now face prolonged ground transport guaranteeing permanent damage or death. The policy creates healthcare inequality where survival depends on location rather than medical need. Banning Canadian aircraft without ensuring alternatives guarantees rural communities lose time-critical medical care. The deaths are not unfortunate side effects. They are predictable, preventable consequences of decisions prioritizing airspace sovereignty over human life. 2 hours ago, Trump banned Canadian air ambulances from American airspace claiming sovereignty concerns. 1 week later, 47 rural Americans are dead from medical emergencies where Canadian aircraft would have provided transport within survival windows. Hundreds more face permanent disability from stroke and heart attacks that could have been treated if air ambulance access existed, and entire regions of rural America have lost their only practical access to advanced medical care. And right now, Canadian Medevac helicopters are sitting on helipads in Winnipeg and Toronto ready to launch for medical emergencies, but they cannot cross into American airspace to save American lives even as rural emergency dispatchers receive calls from heart attack and stroke victims knowing that the only aircraft capable of reaching them in time are grounded by federal policy that values sovereignty over survival.